Welcome to the Module 10 of AI in Healthcare, an initiative by National Board of Examination. To take us through this journey, we have two eminent speakers, Dr. Rahul, who is going to teach us on that, and Dr. Devyani, who is going to moderate this session by reading the questions on the YouTube chat. So please don't post anything other than the questions in the YouTube chat box. I'm seeing a lot of attendance. Please refrain from that. A short introduction to our speaker, Dr. Rahul Kashyap is a medical director at Wellspan Health, York, associate professor of medicine at Drexel University College of Medicine, and research scientist at Mayo Clinics. Dr. Devyani, she is a trained geriatrician and rheumatologist at Harvard Medical School. Welcome, Dr. Rahul. Over to you.
Thank you so much. Please let me know if you can hear me well.
Perfectly correct, sir. Go ahead, sir.
All right. So it's an absolute privilege and honor to be here today to talk to you all about AI in medicine, and especially touching on some of the points on how there are some tools you can apply to evaluate the AI models in medicine, which is actually useful or it is done ethically and without a bias. Before I start, I would like to share this quote from Charles Darwin, which says that it is not the strongest species that survives, not the most intelligent that survives. It's the one that is more adaptable to change. And today I'm going to talk about that change, that this AI in medicine is another major change in our human history. So as I start, let's share that what next 35 to 40 minutes, as you are dialing in today at 4 o'clock IST, I'll talk about the history of technology changes, some data. With no AI cannot exist in thin air. It has to be backed up by good and clean data. Some uses of AI right now, as you are witnessing it in your practice or in your education or around the world as well. My background is in emergency and critical care for past 20 years. I would like to share some examples from there, that what are the use case scenarios for using an AI as of today for last several years. And then we'll share a couple of slides on humane checklist, which we did a validation several years ago, and humanely framework, which was prepared with some of our collaborations. Then I'll leave you with some opportunities and cautions as you young physicians, nurses, respiratory therapists, pharmacists, masters and PhD students who are listening to today, that what caution you should be applying for. I will leave you some tidbits, so look for this particular sign. If you see this sign, those slides are to pay more attention to, and I'll emphasize on that one as well. So let's start. The technology change, what are the lessons from the history? And everybody is right now at the edge that, oh my gosh, AI is coming in and they're going to take our jobs. So I would like to tell you that what has happened in last certain years. Let's go back like 100, 150 years ago, when the biggest technology change happened, when the farming based communities, we moved as a human, we moved into industry specific. It happened 150 years ago in America, around 100 years ago in India. And I've given this part, like, in 1719, America, roughly 90% workforce was employed in farming. And now it is less than 2%. Second thing, in India, as you would keep hearing that as well, almost 100 years ago, the population who was working in farming was roughly 88 or 90%. In last 100 years, it has come down to roughly 60, 65%. So basically, 1% every 3 years has moved away from farming and then went to industry. More people are employed now compared to what it was in 1921 or compared to it was when it was in 1800s in America. So this major changes happened. People went into technology thinking, oh, if the machines are doing our job faster than us, then people will be unemployed in farming area. That was not true. People acquired more skills and different skills. And there were more people who were actually at the time employed. This is an example. The first iron bridge was opened in 1781 in England. So this is a recent history. Human history is for many, many thousands of years, but human history just 100 years old. Now let's look at some recent example. Raise your hand or just have a smile if you have ever been trained on what you call it as a typewriter. ASDFG semicolon LKJH. And in my 11th standard in Jaipur, I was just learning that. I realized that is the biggest technology. If you know the typing, you could be a hot commodity. And same thing, 40 years ago, there's a transition happened where from typewriting to computer typing or desktop or laptops. There was a concern at the time as well that if computers will do the faster typing, they can print out faster, maybe we'll not be employed the people who have own skills of typewriters as well. But that is also not true. You know that in last 40 years or last 30-35 years that more people are employed. There are more admin assistants where they have jobs with the help of computer, not less people. That's a second technology change at least I have seen in my lifetime. Similarly, third change we are going through now as well, as we are looking into traditional healthcare or traditional medicine, which is changing in front of our eyes, use of AI, may it be in diagnostic, may it be in robotic surgery, may it be in remote monitoring, or personalized treatment as well. This change is happening as well. And the fear is that, oh, AI will take our jobs. I think we have seen it at least in these two examples that no, AI will not take our jobs. People with AI will take up jobs, doctors with AI, nurses with AI who have those skills. Today's discussion I would like to set up is as we have gone through this workforce transformation from agriculture based 150 years ago to more and more industry based revolution, and now same things happening while traditional medicine versus AI based medicine. And that's the whole reason of having these webinars. I'm thankful to organizers to inviting me today and setting up this successful lecture series to all of you guys. I've heard like more than 50,000 people sign up and 5,000, 10 or 20,000 people listen to it as well. So walk with me. We have seen this before. The goal is to acquire the knowledge. The goal is to become familiar, start using it, start evaluating it, and be there on the table where the decisions being made for us as a nurse, as a medical student, as a resident, fellows, and faculty member, pharmacy, or master student as well. So I have convinced you today that take the anxiety away and see what we can learn to move forward when it comes to AI. As I mentioned earlier, that without data, without clean data, AI cannot exist. And you have heard this term already, GIGO, garbage in, garbage out. Like if you put the bad data, the models and results will come out, which is going to be bad. That's your first point here today, which I'm sure many of you are already aware of it, that as well, that when you are developing AI models, pay attention to your data. If data is clean, you will have a better model and the model will be reproducible and you can actually validate that model too. Now, there are issues with healthcare data, and I put down some of these things as well. Data may not be complete. The quality might be low. There might be missing data. Uh, the data may not be easily accessible because it's so much fractured across the system. You may have imaging data in imaging software, then you have clinical notes. There might be scan notes, ECGs, you name it. All those things may not be easily accessible to scientists, to physicians, resident nurses, to you, or it may not be connected across the system. Even the same system, I don't know if you're familiar with Epic or Cerner. These are the massive electronic medical record companies here. Many of the hospitals use them as well. Even one system or one hospital in the same system cannot talk to the second system until you have some of these large electronic medical records. And validity, we'll talk about this point throughout our process, that if your data is contain outliers, can you validate it? Does it reflect the patient population you're looking into? So there are issues of the data. So first thing you should pay attention to, the data being used in my own model, is it clean enough? Or two, the people who have used the data, if that data is complete, are they missing something? Are they exclusion criteria? On top of that, there are complexities. As I mentioned, the data could be not just from digital clinical trials, hospital patient database. We have went through a major pandemic now, pandemic surveillance data, scans, microbiome, some of these metabolites and things like that as well. So this is one of the most complex data set when it comes to building a model or doing AI as well. That's why the field is moving slower than compared to other fields who have moved a little bit faster. But we have to live through it. This is our healthcare data. Just appreciate the complexity and making sure that you're not missing many points out of it. If I'll be doing a live lecture during my classes, I'll ask and raise your hand can you tell me what are the top 10 uses of AI in medicine? And if you're thinking and recalling the work you're doing it as well, you are not wrong. These are the top 10 uses come out if you check them anytime as well, from healthcare administration to surgery, from patient management. But I kind of highlighted some of these things which may be relevant to most of you today. Medical research, medical training, which I'm hoping that all of you guys are enjoying these sessions month after month. Remote medicine or remote monitoring as well. Diagnostic has taken a lot in AI, for that matter. And hospital care, at the end of the day, patient care is important. Now, this is 2026 when we are recording, or you was watching this webinar. This is not new. In major publications for last several years, for at least 4 or 5 years, the talks has been happening, and I'm giving AI related talks for last 3 to 4 years as well. I recall that in the beginning I was trying to convince the audience that no, AI is here to stay. Let's look at it, let's be involved and things like that. My own talk and the discussions on the national and international stages have changed now, where you don't have to convince people anymore. This is happening, they see it in their life as well. And now the talks are, how can we use it better, how can we make ourselves more aware about the changes coming our. So it's been 4 or 5 years now that these things are being talked, models are being developed. AI has been here for last 50 years, but the emphasis on that and the tools which are there, which can make it useful for people like you and I, who are at front in either clinical care or on research, we can use some of these tools and partner. Now, there are opportunities, and let me just bring some of these things. If I think of large language model or agentic AI for that matter, and then take an example of ChatGPT, we have some publications I'm going to share with them in the end as well. They have already used for generating reports. The report could be radiology or pathology reports for that matter. People are using it as of today for last couple of years, creating their templates for notes writing. If you were using electronic medical record rather than writing the notes and you're putting into computer, you can generate these templates and keep using them. It saves a lot of time as well. A lot of AI models, agentic AI, is being used for patient communication. You pick up a call and it goes to agentic AI and they answer the question based on the preformed script, and then it could be utilized to decrease the burden on people who are manning those phones. And same thing for patient education. Now, instead of giving a pamphlet or a flyer or just writing down something on their notes, you can create some chatbots which can provide that education, maybe for discharge after a pregnant mom has been discharged or after the baby is delivered, or patients going out from ICU, or if somebody was requiring COPD or asthma care, you can actually create the chatbots or use some of the off the shelf and then have that creation done. AI is being used as of today in enhanced clinical decision making, where they are used as assistant, where you can not only do what it's supposed to be doing and ask, is there anything else more to be done as well? So you can make them part of your decision making. Only one caution is here is that always keep human in the loop or on the loop based on what you're using it. And what the meaning is that the AI per se may not be as accurate, given it might has flaws and biases and some hallucinations, and I'll try to explain some of these terms later on as well. So the human augmentation of AI in clinical practice in education is very important as of today. It may change in future, but for now, making sure that we are keeping human in the loop when we are preparing those AI models, or on the loop that there is somebody else is looking the decision coming out from those things. Let me share some of the needs, and then this is an example for those who are interested in gastroenterology. In gastroenterology, if you're looking to see what kind of diagnosis tools I should develop or look into, and that's one of the crux of this webinar today, is you can focus on the things which are have highest diagnostic gaps. Here you can see the example of GERD or gastric cancer compared to peptic ulcer disease, which only have 1% diagnostic gap. That means we don't have too much problem of diagnosing these things. However, the prevalence and mortality and cost for those models may differ. So this is one of the tools which you can look up. This is not my publication. I can provide the citation for that as well. So paying attention to it, do we have a major diagnostic gap? What is the prevalence of this disease in my practice? Is mortality high or low or medium, and what's going to be the cost? And that can help you define some of these things as you build up your models or try to look for off the shelf models as well. Let me take an example from those who are interested in sleep medicine. And this is one of the unpublished paper, which I'm showing it to you as well. The innovations in AI in sleep medicine can be from your sleep apnea prediction to your REM behavior disorders, early detection of it, maybe a chatbot based sleep coaching, which I talked about, patient education piece of it as well, or optimizing their use of sleep. Those who are not in the field of medicine, sleep medicine, what I'm trying to explain here is that the AI's use in everyday practice, from detection, early prediction to management of the disease, is rampant. It's happening as of today. It's just a matter of time for us to realize what is more pertinent for us and how we can acquire knowledge into it. I'll share the third example now. Those who are in the field of emergency critical care or emergency rooms or casualty areas, for that matter, uh, the use of AI could assist you in patient journey throughout, from the event happening outside the hospital as a pre-transport to pre-hospital care, coming to triage and hospitalization. Either they come to emergency room and then they go to the wards or floors, or they go to operating room, or they go to a step down unit, and then from there they get discharged. There are chatbots. They could be remote monitoring starting from the field even before patients coming in ambulance. Two, you can follow them throughout the hospital journey. You can predict if they're going to develop sepsis or shock, or their chances of developing ARDS or acute kidney disease that much. Let's do some preventive measures now before they go into that spiral. And this is something you can look into as a published literature, and I will make it available after the seminar. We'll put down into the chat bot in YouTube later on. Emergency trauma care, if I expand a little bit more into it too, first and foremost things what have been used now in last several years as well, you can look into the different injury detection based on the AI tools when patients coming up. With the imaging modalities, you can find the lesions a little bit better and localize them a little bit better as well. And you can have a predictive accuracy when patients are being triaged. For those who are working today or these days into large trauma centers where all of a sudden a lot of patients come in, how you're going to triage them as well. There's a lot of tools are developed within the hospitals in India and abroad where you can predict the outcome, you can predict and triage them, and then manage your resources accordingly. Now, I'll share this couple of points with you as well, that how some of these diagnostic and prognostic works and what you should take care of them when you are looking and evaluating some of these models. Let's say an example, if a convoluted neural network developed for diagnostic use, and it has a good sensitivity and specificity for detecting the injury, diverse injury in the trauma patients. You need to take care of some of the things. You have to look into those literature or your own model. Have they used prospective data? Have they used more than one center data? Is there overfitting happening because they just use a single center, a retrospective study, and then they have not done a validation for external institutions? So that's the first point, is if the model I'm looking at it, have they validated that, and derivation and validation cohorts are there, or have they done an external validation? I'll share a checklist with you that you can apply to read any AI based paper in medicine, and then there's a framework around it as well. When it comes to predicting injury severity scoring, which I mentioned in the last part of it as well, the calibration is going to be very, very important. Have they refined these tools where the lesion localization techniques are used properly, which can heighten the model utility, where they missed out the false negatives. They have reduced the false negatives. Remember, when we are doing AI model building, many times we try to just avoid the false positive and we don't worry about any false negatives. And that is something you can pay attention to if you have knowledge about, like, oh, what they have done it, the people who are missed out, how they have taken in account. Because many places it's okay to be false positive, so you can override that. But if you miss out something, you will never go back to them, as then you'll miss the injury piece of it too. So pay attention to those things. What kind of data has been used, validation has been done, and then what they have done to calibrate the model for that matter. AI is the biggest feedback you will get it, that AI is a black box. You will don't know what it is doing, and then telling you can't explain to it as well. So trying to be transparent about your AI model, telling what data points were utilized, and how it is calibrated for that, and the model's results are coming out of it. If you pay attention to that or try to be transparent, you will gain a little bit more trust among your colleagues or physicians and nurses for that matter, that they know. Because the biggest problem happens is we don't know this tool, that's why we can't trust it. So that is something you can decrease, that kind of mistrust, and try to bring a little bit more transparency when you are developing or evaluating some of these models. Now I'll share some real life examples. As of today, I mentioned that generating reports, radiology is, if you are in this field, is leading the field when it comes to AI implementation in healthcare. I'll take the example of ChatGPT. It can actually, if you give it a non-PHI of protected health information, which another advice I'll give it to you all, please do not put any unpublished data or papers or any patient related information on any of these large language model, because it becomes part of the database and you don't know where it has been utilized later on. But imagine if you're putting something non-PHI and you want to generate some sort of a report and make it recurrent, where then you will save a lot of time as well. AI has shown, and I have some data from our own publications, there is a high degree of accuracy, it is consistent, and it provides clinical relevance. However, there is a caution that these reports may be questionable because sometimes they hallucinate and they don't provide the patient pertinent information. So you can actually look into pre-stored templates for quick reporting, but if you go to a little bit more details, sometimes these models hallucinate or they give you false information. That's the word hallucination is being used. I've shared an example here. If you give a prompt, it can provide a response which is more palatable to explain to the patient if, as a radiologist, you're reporting. Second point I mentioned about patient communication education. There are chatbots now, or agentic AIs in last 2 years or even last 1 year, where you can deploy them and then they can answer patients' queries in a very engaging and friendly environment. These could be very precise and clear, and then these are tailored response for the emergencies or information they're asking, either in radiology and other places as well. The biggest feedback you get it that it may come a little bit impersonal or automated, where people like to be connected as another human as well. There's a lot of advancement has happened in last couple of years that it becomes almost very personal. If those who have used Alexa or other automation devices, you will see that it becomes more and more personal and try to engage you in day-to-day communication. Now, third, another point is about research, and that is something I'm very biased about. My career is involved in medical research, and I teach that too. As of today, or in last couple of years, AI has been heavily used for developing protocols. These are research protocols for clinical trials or drug trials, or even your randomized control trial, which you initiate in hospitals. You can develop a very rigorous and well-designed and efficient clinical trial protocol if you know how to provide proper prompts, and you can evaluate what is coming out from these ChatGPT or Claude or any other large language model. You can actually refine your ideas. I used to remember when I used to write down the ideas on a paper and try to sketch it out and think what it is as well. It comes to designing studies name or acronyms, but now you can do it very, very quickly. The caveat is that you should be able to evaluate what is the outcome coming out from this chat GPT or anything else as well. And if you don't evaluate it well, it might give you wrong information. So be very careful when you get the outcomes out of it. I'm not saying that you should not use it. What I'm saying is that you should be careful and don't trust blindly when you are building some of these things. Nowadays, you can even run analysis or using it, saying, this is my database. And again, don't put any patient information, de-identify data. Can you run X and Y exposure and outcome variable, or give me the SAS codes or any other codes, and then use that codes in your system as well. Generating headings and other things is also an important part as well. I've done a study in critical care medicine where it completely hallucinate and create false references. That was a very, very early version at 2.5 years ago. Now things have changed a little bit, but just be careful that it can give you false information, it can hallucinate, or there might be biases as well. Let me share that example with you. So this was a manuscript which we're talking about, that we try to evaluate ChatGPT or large language model. We give an example saying, hey, ChatGPT, can you write a small abstract background section for, let's say, I think sepsis and acute kidney injury. Then we ask to one mid-level professor and a senior professor, the same comments we gave them. Hey, can you write down 150, 200 words, a background for us using the same principles we gave you to ChatGPT. Then we asked people who have published at least one paper, 80, 90 people, either doctors, nurses, medical students, resident pharmacists, computer scientists. We asked them, can you look at these things and tell us which is written by computer, which is written by AI, or which is written by humans? Guess what? They could not differentiate. And we asked a second question: what is it? Is it which is better? And then ChatGPT hands down beat both the mid-level professor and a senior professor. And we ask these questions: why the topic is important, it's already known in the field, and what's the knowledge gap, and what's the aim of the study. So, and this is the all the difference are significant. People are blinded, and this became the first publication in critical care medicine evaluating ChatGPT, and several other papers have come out of it. So these are the few things you can do at your end as well. If the area you're interested in, may it be nursing, pharmacy, may it be GI, OBGYN, psychiatry, whatever you're interested in, you can do certain things to evaluate and find out which large language model is better than others as you go through. This is not a research 101 lecture, but I want to share this. I'm sure you are familiar with this. It's Equator guidelines, and if you're writing a randomized control trial study or observation study, you have familiar with using consort diagrams or consort checklists or stroke checklists or Prisma for that matter. Without that, nowadays you can't publish any paper. In that line, I would like to share a humane checklist, which is used to validate the papers you're reading in AI in medicine. Idea is you don't know what to validate, and this is a 50-point checklist several years ago with a large collaboration in India, US, UK, Australia, and UAE. We build up and validate that. I'm going to share that with you in next couple of slides as well, to how to read an AI based paper or a paper which has AI model, or when you're writing it, you can take care of those points, make sure that it is highly acceptable and publishable. Humane, so this is reporting guidelines for humane, and I'll share that with you. It stands for Harmonious Understanding of Medicine Learning, Machine Learning Analytical Network. And this was a global consensus paper with my collaborators, Dr. Padmanabhan, Piyush Mathur from Cleveland Clinic, Sandeep Reddy from Australia, and others who have helped at the time with validating this particular checklist. I'll share this checklist link with you in the chat box later on too, but let me walk you through for next 5 minutes with this checklist. For when it comes to title of a paper, abstract, introduction, background, method, making sure that the title, when you're writing a paper, evaluating it, they have actually mentioned AI or machine learning in some form in the title itself, if it aligns with any of these terminologies. When it comes to abstract, the typical formatting of abstract, their objective, study design, target population, and then results, analysis and results, they are all pertinent to AI and machine learning in healthcare. That's your first thing. You can check it, that if title is talking about it and the abstract has mentioned it. Otherwise, what's the point if they just make it a side comments in there as well. When it comes to background, as you see that we have also used the same checklist. I think what is known in the field, why it is important, what's the knowledge gap, what you did to fix the knowledge gap as well, and they define the objective based on the validation and development of AI and machine learning. So idea is that, and then they have picked up the domain. So majority of the studies you will see or evaluate in your practice would be either they are based on triage, early diagnosis, improved diagnosis, personalized treatment, prevent or reduce hospital admission, and improve survival. I'm talking about non any not typical radiology or pathology related things, but if you're looking to clinical medicine, surgery, OBGYN, psychiatry, or family medicine, one of these things will cover 90 to 95% of AI models you will evaluate in your lifetime for now until the newer technologies come out. The emphasis in this checklist and for you is that looking into method very closely, and then we have divided that into massive subsections. Looking at the data source, are they using, is it perspective, retrospective, derivation, validation, cohort, supervised, unsupervised machine learning, and so on and so forth. And they will mention about it, and you can go and read about what does it mean of these things. Many of you already aware of it, so it might be too simple for you. The timeline they have mentioned, did I use retrospective data from what year to what year? If it is on data, is how they obtain the data in the care pathway, because you can't talk about hospital admission if you're only looking at early diagnosis piece or triage piece of it. So make sure that they pick the data from the care pathway, and they're talking about that itself. There will be some pre-processing details or pre-curation details listed there. If that's not listed, that means you can't, they're not being very transparent and the model could not be trusted. Of course, the appropriateness of the data, if it's a healthcare condition, they're looking into it as well. And then I cannot emphasize enough, a training data set, testing data set, or validation data set has to be clearly identified. On top of that, there should be external validation. So these are the first 15 points until method. Now let's go for other method points as well. If they mention about approval from IRB or patient privacy or ethical committee and so on and so forth, it's very important. Even though they may not be using any protected healthcare information, but they might have done some exemption and things like that. If they've used the data on live patients or prospectively validation, they have to have patient's consent or IRB exemption for that, they have not violated patient's privacy. Then consent piece of it, then outcome has been defined properly. Again, same in the training, testing, and validation data set as well. Focus on the triage and diagnostic pathway they applies to their, if that's what they're using it. Statistical analysis, there has to be a pre-specified analysis plan. They've looked into accuracy or precision or sensitivity, specificity, area under the curve. All those things has to be defined well in the method section before they get to the result section as well. And this ground truth of labeling of the data, those who are listening today and are involved in data modelation, data model, AI model building, how important it is to have these labels, because you will compare your results against these labels as you're training computers or AI algorithms as you go. The last piece are including some of these manually done automated journal and things like that. And it has been reviewed by an expert as a gold standard. And then it goes through the typical points of results and discussion. I'll not go into that detail. You can read it and there'll be a link available to you as well, that they have described these key demographic and listed these things and then reported their discrimination values and performance values as well. That they provide the discussion as a primary result and compare the result and strength and weaknesses and so on and so forth. And ultimately, they have listed their conflict of interest, that, did they get any funding or they're part of any company and things like that. It's an extensive list, but it is the first step for you to start evaluating any AI-based papers or models which you're planning to implement in your hospital system or in your clinic, or you're publishing papers on them, could be a good guide for. All these points may not apply to all the papers, but most of these points should apply to all the papers. We end up, and see, I've putting some of the alert as well, that this is one of the things I would like you to pay attention to. Now, this has been validated in hypertension medication literature. Dr. Padmanabhan and their Clea was their PhD student at the time, and Dr. Nawaz and Dr. Sandeep Reddy and other Dr. Vishweshwar, and some of these were involved in validating this in hypertension literature. And that's an opportunity for you. You can use the same checklist to validate or evaluate the major papers published in your field and publish them as well. Now, I'm switching gears to share another framework called Humanely Framework. This is developed by Dr. Piyush Mathur at Cleveland Clinic. He's very active in last 10 to 12 years using his BrainX community, where developed this Humanely Framework, which is an open source evaluation for large language model. The humane checklist, which I share with you, that covers each publication in AI. This one, you can actually use an open source web application to find out the LLM outputs in this regard. It's been published in Nature, I think recently, several years ago, or late last year. He divided the team into 5 different points. The relevance of the model. Can you contextualize the accuracy and reasoning? If the model is coherent, the grammatical and full form of organization. It is comparing the responses of different entities, then coverage, and is it creating any harm in this model? So this kind of gives you, and this is a free app website where you can go to brainx.com/humanly, where you can, this is open access and then there's no cost to anybody. This is the table 2 from the publication I put down in here in Nature, where it goes through these metrics of relevance, coverage, coherence, and harm, and then comparing it as well. And then there's sub-metrics around accuracy and other fluency, and then privacy and bias and hallucination and things like that. It's a very good framework for you to evaluate any AI algorithm or before you employ it, or at least you evaluate it as well. I strongly encourage you to use and test it out as well. I have no conflict with any of this, but I think this is something I wanted to bring it to you, that this humanly app or framework could be very, very useful those who are listening today. We are almost roughly at half point of our talk, and I have another 15 minutes or so, or 10 minutes or so to go with it as well. Let me just share some of the opportunities with you, and I've taken the example of um, trauma and care with injury prediction to triage. Imagine that AI can predict the severity of motor vehicle crash, which still is an issue. And I published a paper several years ago looking into the road traffic accident in India. Triaging, you can it could be utilized, and then system can help you out as well. And then managing your volume for emergency department using AI. So these are just opportunities in one particular area as we go through. Then you take it further with the patient outcomes and image screening, who's requiring and detecting some of the most common fractures or injuries and things like that, using AI in radiology for that matter. If I switch coming out from the critical care or trauma and emergency part of it, think of pharmacy industry, those who are doing that kind of training. AI has hastened the drug development and decrease the cost for it. You can actually, instead of looking at thousands of molecules, you can very quickly narrow it down as well. And instead, spending a lot of money, you can cut down the cost by 7 times. Patient monitoring is important, and that could be done as well. Some of the rare disease detection or developing the therapies around it has been hastened through the AI as well. I cannot emphasize enough that AI has helped and is helping in creating personalized care for our patients in India and abroad. And then that is also, if we are careful enough and avoid the biases which are built in AI, or if you're not careful enough, there could be a disparity. But AI could be utilized to provide equitable care without any biases, whether skin color or language or other disparities. I thought of keeping this slide for you, those who are involved in administrative side of it and revenue cycle management. If there is a coding and billing, which is pretty common here in America and other places, AI has been used nowadays. I started giving this talk when it was still building up. You can use it during the patient encounter using Scribe AI, where it can listen to your interaction with the patient in outpatient setting and can tell you what are the billable codes as well. And we have done a validation study in Dubai 2 years ago. You can actually, instead of a human coder, AI can do the coding after the fact when you look at the records in healthcare in the inpatient patients as inpatient or outpatient. AI nowadays can predict what is highly likely to be denied, and then it can correct it before it goes on in claim submission. And then second thing is you can have deployed chatbots for these denials and appeals and things like that. So just 4 or 5 steps out of these 7 steps as of today. There are different solution providers who are working on these areas as well. Unfortunately, there's not one solution which can cover all these parts, but those who are interested, I'll be happy to talk to you about it. Now, I'm a scientist, I'm a researcher. That's what I do as I train people. And then many a times we say, oh, we don't have any money, we don't have any funding. Can I still do some of these things? Can I still build the AI model? Or can I at least do some work and research work and publication in AI? The answer is yes. What you can do, it has been yes all the time. I'll share some of my examples. But we live in 2026. This video is recorded today in 2026. What can you do in next 5 years, 2 years, or 3 years as you go through? Let me share some ideas in which our team has been done, and then you can take any of these ideas and build it. Excuse me. I share with you the cross study where evaluating ChatGPT or other AI models to find out how good they are in writing abstract on things. We did not write the paper using AI, but we evaluated how good and bad it is as well. When people are using AI, ChatGPT or Claude, and they might go into more deeper conversations, and then there could be a stress around it. So we end up publishing a paper called AI-induced or AI-associated psychosis in adolescent, especially in teenagers, and it could be for adult as well. So you can write a review article on the topic based on what you hear as well. This was published in Mayo Clinic Proceedings, so where we looked into redefining medical documentation using AI, how useful it has been. In addition to that, writing papers on the field, moving it. If maybe in sleep medicine, a survey done among Indian and UAE and American medical students of 1,200 students, looking into how ready they are to use AI in medical education. Same thing could be done in nursing and pharmacy and respiratory therapy education as well. And then asking AI to translate things into different languages. So AI miracle paper was done in changing into converting English into Hindi, Mandarin, Spanish, Tagalog, and one more language, 5 languages as well. So these are some ideas. You can work your own idea without any funding. You don't need a clinical trial design. You can actually do these things with the IRB exemption or ethical committee exemption. I will not have enough time to go over, but this is one thing which I proudly share, give a lecture on how you can bring your idea from clinical case reports to review article to creating a survey and creating a case control or cohort study design and doing a meta-analysis before you start thinking of doing a clinical trial. And I've shared some examples in the previous slide and upcoming slides where some of these things could be done for no cost and minimal money. And I encourage you, those who are listening today, that you can write a paper as of today. Once you start working on it and your idea, have a good PICO and work with your mentors and so on. So there are some cautions. I cannot, I touch base on some of those things and I'm getting into the last end of my talk. We are 19 minutes away and I want to have at least 10 to 15 minutes of time for question and answer. As I mentioned, that AI is a big black box. So, how you train your model without knowing it and what kind of transparency you like to bring in or like to see as well. That's a quite good question for you. So pay attention to that. Their ethical consideration, especially AI will not have human emotions. Sometimes they will be cut and dry. So you have to make sure that there's enough humans in loop or on the loop when you're developing it or when you are making a decision tree. Their ethical consideration are taken care of it. Their biases in algorithm, and those who are listening today and you'll become AI scientists in future or in several months from now, pay attention to it. If we don't do active intervention, the algorithms are going to get more and more biased against females, against children, against people with the disadvantages, race and ethnicity background. I can tell you that. So you have to be the champion. Make sure that am I introducing a new bias or am I taking care of the biases best to my abilities? And my emphasis on human augmented AI, when I mention about human in the loop when you're building the model or human on the loop when you're using the model, is going to be very, very important. As you use large language model, and I really wanted to talk to you about this as well, that please pay attention to what kind of information you're putting into large language model, ChatGPT, Claude and all. Don't put any unpublished data or patient private information or your private information on these models, because it become part of the international database and you never know where it gets output out of it. Their hallucinations, we found out, and I'll share some examples with you, that once you put AI generating images or generating context, it hallucinates pretty bad. If you press it hard, it is going to agree with you as well. That's we have noticed in some of our papers when we try to validate them. You last slide also, it will create a bias, it will amplify it if you keep pressing it. So that is something you have to be very, very cautious as well. Validate anything is coming out from these models or these outputs with your clinical background, your education and training, and look for the scientific accuracy. Sometimes the things could be just statistically significant and may not have much clinical value out of it. So to end my talk, I just want to share this with you, that you can ask to create AI images, and now this is old. I think this is 2 years ago, 3 years ago I created them. It can hallucinate, it can utilize in patient education, it can hallucinate, but the point it is that AI could help individualize our education. Not everybody will learn the same way. Some people are visual, some people are writer, they can read it. I'm a visual person. So now we live in an era that we can actually have a proper use of AI outside the medicine, where we can use it for in schools and then individualize the education for everybody else. My wish list is that AI could do dishes and then laundry, so then I can keep working on music and painting and things like that as well, because we don't want them to paint and create the art, versus they can do some of these mundane tasks and then we can focus on high value work as a humans for that matter. Caution, when I created this, I asked them, hey, can you create me a robots which are doing laundry or dishes, and it ended up mixing those things as well. This is a good example that it can just create hallucinate. It's so obvious here now, but once you go into more details, and these kind of lacunas may not be that much obvious, so you have to be very very cautious. It mixed the both laundry and dishes at the same time. Imagine how much it is doing it without you knowing it, if you're looking into the text part of it. So I'll leave you with this. Today, I hope that you're able to appreciate that AI is becoming a part of medicine in some capacity, either in personal use you're using it, or hospitals, or triage, or and whatnot. Be appreciative of the healthcare data, the vastness of the data, incompleteness of data, and complexity of it. I share very quick examples of some trauma and emergency care, some radiology reporting, patient communication, education, remote monitoring, and so on and so forth as well. There are much more needs as people are using in India and other places for that matter. I've shared with you a humane checklist and humanly framework to evaluate these papers or these models before you start implementing them or start thinking them as well. And there are tons of opportunities for you as learners and the future of the healthcare in India and abroad, in triage and administration, patient outcomes, drug development, and rare diseases, and providing equitable care. You can never be cautious enough, so that's one of the summary points I want to make sure that making sure that you guys are paying attention to what is coming out of it and being engaged there, so then you can help improve it. With that, I'll leave you some of my contact information. I'll be happy to be connected on LinkedIn. That's where I live. I do the hashtag mentoring in healthcare on Twitter, on LinkedIn as well. And then these are some of the publications I've done in last several years. I'll stop here.
Devyani, over to you.
Oh, that was a wonderful talk. Thank you so much. I learned so much from this. And I think to follow the talk, there are some really nice questions that are flowing in. I'm going to start from the top. There's an interesting question about when the AI prediction is not in line with your clinical judgment. So the question was like, if the AI predicts it's sepsis, but I don't treat, but the AI predicts there's no pneumonia, but I still treat, is that is that decision making? What's the take on decision making? I think I know the answer, but I'll let you answer it.
No, go ahead if you want to, and I'll chime in.
No, I think clinical decision making still stays with the physicians. So your decision is probably uh, the way to go. But what do you think, Rahul?
Yeah, no. So I think good question. At the end of the day, nobody's gonna blame AI. This is you as a physician, as a nurse, are responsible. So you are responsible for all the actions as well. Here I'll say, if you have to take care of one or two patients or three patients, you will do an amazing job. You'll not miss anything. You'll use the search criteria. You use the new SCP guidelines. You'll use everything possible. But at the same time, when you're taking care of 20 patients, you might likely to miss something because you may get tired and may get distracted with some more acute patients. That's where AI comes in picture. It's flagging you that, hey, this patient is likely to get sepsis, or this patient is having sepsis, or this patient has shock going on. And then that might be alert goes in your mind saying, let me go and double check if it is true or not. You can always override, no, this is not sepsis, I've treated pneumonia, there's nothing else, well and good. But these, when alert comes in, kind of gives you in a busy day that you might have missed it, because computers and AI algorithms, they do not get tired. They keep doing what they're supposed to do if you put the rules right. So I would agree with Dr. Devyani that, at the end of the day, it's your responsibility. These could be used as an alert for you if you get busy or you don't have enough time to focus on minor details.
Wonderful. So the next question comes as, how do we utilize technology to help patients who are not literate? So that's a good question too.
Very good question. Yes, oh my gosh, you guys are amazing. So there could be multiple things, like, when I say that, are you hungry, or are you cold, there is no literacy needed. There are there are things which all languages kind of same. So if patients are literate, instead of creating a text-based approach, AI chatbots can create educational videos in the local language. And the beauty is nowadays is you create a video in English or any language, and you can ask AI to superimpose any local language, maybe Gujarati or Kannada or Tamil, Telugu or Marwadi for that matter, or Punjabi. You can have a chatbot translate into local language. So this is something which I say that this is a boon, that you don't have, AI can help you create non-text based language education things which you can actually translate in any language now.
Wonderful. And then the next question comes: what kind of infrastructure is needed for it to work? So does the entire system have to work on the same platform for the AI to work? I guess they're getting at what kind of platforms needed.
Yeah, so if you think that, okay, my whole hospital has to be in certain EMR or has some certain platform and system, things may not work that way. I'll give an example from America. Whole hospital or system might be in Epic EMR or Cerner EMR as well. These AI models are built and developed in certain areas of the needs. You build in something which you have good robust data in radiology or in pathology or in emergency medicine, and then you are focusing on those focus questions, what you are trying to solve, what's the problem you're trying to solve. And that's something I missed out, is always start with the problem. Don't come and saying, hey, I have this cool tool which can do this. My next question is, okay, what is the problem you're trying to solve? Oh, I thought it's just a cool tool. Always start with the problem. What problem you're trying to solve? Are you trying to solve a problem of a patient's outcome? We can't detect these things early enough, or we can't have a better treatment. Or you're trying to solve a problem for a process in the hospital, or you're trying to solve a problem, the interaction between patient and the physician. So start with the problem, what you're trying to solve, and then build your model. You need a good data. Things can be built and developed using good data and spreadsheet. But implementing that has to be something which you have to work with your hospital administration or your clinic administration to see that they can implement it. So I will leave it. It's a deep question, but point is that having a large healthcare system, big EMR, may not be the limiting factor for you to start building something small in your work area.
Wonderful. Thank you. I think there were questions regarding 3 clinical scenarios. One of them was laryngeal endoscopy. The other was end of life care and palliative care. And the other one was integration of the strength of orthopedic implants. So are there models that, I guess, predict these anything in these specific clinical scenarios?
Yeah, so I don't think so. I have the authority to know or tell that, I know the literature completely, but I'll share some examples which, I've been involved, at least I've been consulted on. Imagine for first one was a duodenal carcinoma, is that right? What was the first one?
Laryngeal endoscopy.
Laryngeal endoscopy. So let's take that example. You did the endoscopy, images are coming out, and there could be 3 types of images. One is very definitive, that there is a lesion or there's an issue, or there is, if you take any example, if you're looking for cancer in GI tract for that matter, and something which is completely negative and something which is in the middle. Idea is that take this example and think in your diagnostic approach that you can create models which focus on this middle point where there's not enough, there's ambiguity around. You don't know if it is positive or negative and you like to miss it. So you can train and develop model enough to feed enough images, which is the raw data, and you label them and use it, have the, what you call it as a gold standard comparison. And then model can be trained and tell you now. So what you can do is sometimes you do a repeat endoscopy, sometimes you do a repeat imaging or biopsy. You can decrease them by even 10%, 20%. You are saving costs, you're saving the pain, you're saving the hospital infrastructure. So if you take this point, that whatever you're doing it, they are always either you are 100% sure, you're 100% positive, negative, and there's some middle point where you're not sure. You can build models in the field, any of the field you're mentioning in, which can help you decrease the uncertainty by 10, 20, 30%. You are already winning.
That's good. I think do you have anything to say about end of life care decisions?
Yeah,
that's slightly different from the sort of imaging and the endoscopic predictions.
yeah, and I think I would like to see if you or Dr. Suresh also have some comments on it. End of life or organ donation, and some of these things are, it's highly sensitive topic. We have to make sure that we are using full empathy and trust building measures in this regard. I would not jump into AI models on these topics first if you've not done anything other places. I would like to work on detecting diseases better earlier. I would like to work on improving our patient outcome pathways better, then come to some of those things. I'm not familiar with, and that's not my body of work in looking into end of life care. We have done some work in the past time when we try to create some educational videos to differentiate between what is the full code means, what is do not resuscitate, do not intubate means, as well, to provide more education to the patient. That's what I'm talking about 12 years ago, 13 years ago, before all AI in medicine came in. So I would start with creating some of the education around it among the staff member, among the patient and families first, and then see that how you can deploy some of those things when you know that it is with full of empathy, and then there is ethical consideration has taken care of it, because
Yeah.
you can't just jump into that without knowing if it is going to predict well or not.
Yeah, I agree.
Yeah,
Would
Dr.
you like
Suresh?
to say something, Suresh?
yeah. End of life in oncology is always a challenge. And predicting that a person is going to die at some point of time is the last thing that any medical doctor would like to do, right? So how to ease the terminal part is what requires empathy and not AI. Currently, I don't think AI is into that zone. Completely second what Rahul and you are telling. Thank you.
Great. I think there's a little bit of a shift in the questions towards research now. So the questions are like, do we have to always declare and disclose AI has been used to prepare the protocol? Yes. The short
Yes.
answer is yes, you have
Yes.
to.
That's my favorite question, because I train a lot of medical students, and I start seeing them like, oh, they're publishing papers. Like when we did the whole project, now papers are coming to me in less than 1 week. That means there's some use of AI, and then it's so idea is that the all journals, and I'm an editor or associate editor for several journals and publish myself extensively. They require you to disclose it, and this is a good practice. If you have not used it, disclose it too, that there is no use of AI in this manuscript, but there's certain language you can use it, that XYZ tool was used to improve the language and grammar in this part. At the end of the day, me as an author takes the responsibility of the content, because AI cannot be responsible. So absolutely, if you're using it, we encourage you to use it in some capacity so you learn and become better, but definitely disclose it. When it comes to reviewing the papers, there is still juries out, but most journals want you not to put any unpublished paper you are putting in. You are reviewing it because you are putting an unpublished information of somebody's work on these large language model, and God knows where it get out, and then somebody else publishes sooner than that. So there is a big no. Don't put unpublished papers as a reviewer. But if you're using AI to write your papers, or at least polish it, write in a clear sentence, and I can provide you, if you read couple of our recent papers, we have put down that disclaimer as an acknowledgement section.
Yeah, I mean, from my experience in the editorial world, I'm part of multiple journals. There are tools to pick this out too. So, detection, there's an inherent tool to detect that if you've used the AI and haven't disclosed, we'll find out. So, no point in hiding it. So, that's one
Absolutely.
thing. And I actually heard from one of the very high impact journal in medicine from their editor how data was fabricated using AI, and so how they had detected it. So if you're smart to use AI for writing it, we are smart enough to detect it also. So
Yeah, and that's a good point, that especially a lot of I would say that unethical work is being done in when it comes to images and data fabrication. So avoid that completely, because you don't want that in early part of your career. Number one. Number two is journals will find out, because they use these tools as well. So, and you'll be banned from them. So please be ethical, no matter what it comes to clinical care, patient interaction, or research.
similarly, someone is asking about AI writing abstracts. So I think you covered that in one of your talks. Are there tools to use to write abstracts? Okay, so one of the last questions is AI role in cancer prediction. I guess using both genetic and environmental factors, how to incorporate the multiple factors in template for prognosis and treatment. I think Suresh kind of alluded to that.
Absolutely, yes. So currently, we need to stick the treatment decision based upon the approved guidelines. Prediction beyond a point is not enough. But if you are really keen, there are some approved tools which uses the standard models. Everyone is calling it AI, but AI is very vast, starting from the simple decision-making trees to the ML. So be cautious when you do that. My recommendation is don't do the multi-modeling unless it is mature. I hope,
Yeah, and
Rahul, you agree?
yeah, absolutely. And I think you brought one point is that many a times the glorified statistical analysis is called an AI. That's not an AI. Making sure, as I mentioned, that make sure that they've used some of these things. You know, it's a supervised machine learning or unsupervised machine learning. It's a convoluted neural network. What you have done as well. So be careful. And there's trials and studies which I'm aware of where using some of your blood samples to see if you're highly likely to get that particular disease. So the prediction of some of these familial hypolipidemia, Lynch syndrome, some of these things are easy to predict now, especially apolipoprotein B and some of those things. So we are living in a very exciting time where as the field is advancing faster, we could actually find out if it is a higher risk of certain things, so it could be breast cancer or Lynch syndrome and whatnot. And you can do preventive actions or you can do lifestyle and behavioral changes where you can have less and less risk. So 100% agree. There are studies and trials which I'm aware of it, and I'm sure that we just launched a quality of life registry among cancer patients. So this is a plug for those who are interested, and you can be partnering them as well. Suresh, I'll reach out to you later.
Absolutely. So I think we came to the end of this session. Thank you very much, Dr. Rahul, for such a wonderful session. Dr. Devyani, I think we missed more than 200 questions, but we have only 10 minutes. We can't do better than that, right? So thank you, both of you. Over to you, NBMS, if you have any comments to make before we sign off.
Thank you, Dr. Rahul, sir, and thank you, Dr. Devyani, ma'am, and thank you, Dr. Suresh, for this wonderful session. And thank you, all the participants, for joining the session. Thank you all.